Thank you for joining us. Hi from New Mexico, or hi in New Mexico. I'm in Buffalo, New York. Again, I'm Dr. Jennifer McVige. I'm from Dent Neurologic Institute in Buffalo, New York. I am a pediatric neurologist, but I practice pediatric and adult headache medicine. I run the concussion center here in Buffalo, New York. I work at the Dent Neurologic Institute, and I am happy to speak with you guys this evening about pediatric patients and migraine headaches. So it's about 8:01, so I'll get started a little bit, and then I'll talk for about 20 minutes and give you guys some information. Hopefully that will be helpful. Thank you for joining us this evening if you just logged on. And at the end, I'm going to give about 10 minutes to field some questions if you have some questions. So we'll get started, and you may hear me stop to introduce myself again midway through, just for the new people that are joining. This is a very big challenge, a very big issue in society, and I think sometimes it's overlooked. Kids are not just little adults, and that's the reason why I love being a pediatric neurologist and helping pediatric patients. You can make a huge impression on these young people. Given the fact that I practice pediatric and adult headache medicine, I find that I end up taking care of the whole family. And it is a nice thing because you can educate the parents and the children. Oftentimes, you'll find a genetic component where there is an inheritance pattern where the parents have the migraines and the kids have the migraines, and we can do education for both individuals. So why is this a big issue? Many of you who have logged on obviously are interested in the topic, but some just statistics to put out there for your education. Up to 82% of adolescent patients have reported having a headache before the age 15, a significant enough headache to report it. Approximately 6% of adolescents experience migraines annually, and this is a true migraine headache. The thing to keep in mind is that migraine headaches with children can be just as disabling as they can be in the adult population, and kids experience pain just the same way that we do. They just have a difficult time communicating it sometimes, so this is the challenge. One study by Dr. Silberstein, Lipton, and Dodick showed that as we age and go from 3 years, 5 years, 7 years to up to the teenage years, that the prevalence of headache increases by year. So at 3 years old, we can see 3 to 8% of kids will complain of headaches. And then when you get up to 7 to 15 years old, 57 to 82% of kids will complain of headaches. And that's just headaches in general, not particularly migraine, but it is an issue. Interestingly, just again for some headache frequency information, chronic daily headaches are defined as 15 or greater headaches a month that last more than 4 hours a day. And what they found is that this is more prevalent in young girls, 2% versus 1% approximately, and more prevalent in non-Caucasian individuals, 2% over 1% of individuals. That is similar for the high-frequency episodic headaches as well, which is 10 to 14 headaches a month. So again, this is a very big issue for these kids. So let's talk a little bit about obtaining a history. The way that I obtain history from children and from adults, instead of asking them how many headaches do you have a month, is to actually ask them how many headache-free days you have a month, and you get a very different answer. A lot of times people who have had migraines for a long period of time will kind of downplay their symptoms because they're just so used to being in pain for so long. So asking them how many headache-free days you have is much more constructive, especially if you're a parent and trying to get the information. And I'm just going to reintroduce myself really quick. Again, I'm Dr. Jennifer McVige from Dent Neurologic Institute in Buffalo, New York, speaking on migraine headache in the pediatric patient. I am a pediatric neurologist who does practice headache medicine in adult and pediatrics, and I run the concussion clinic here for those of you who just joined a few minutes ago. One of the things that I did want to discuss that I get a lot of questions about is what are the red flags in a child, especially? What are the things that we would look for and be concerned about? Because as a parent, I know any headache is concerning in a child, but some types of headaches are more concerning than others. I have a lot of parents that will come in and say, you know, we went to the ER, but the ER did not do a CAT scan on my son or my daughter. Well, we don't always want the ER to do a CAT scan. There's radiation involved with CAT scans. MRIs do not involve any radiation. So you should leave it up to an expert to make the decision as to whether the child should be imaged or not. Some of the typical red flags that we see for headache would include less than 5 years old, a child giving a very distinct history of, I have a very bad headache right here, and giving you a very specific location. Under 5 years old, typically kids are not able to give that information, and then it is pretty bad in that situation. The exception is that when there's a parent that has a migraine, and sometimes the kids have a learned behavior because they hear mom or dad saying, you know, oh, I have a headache right here. And so just think back to how many times you said that in front of the child and make sure that that's not why they're saying it. Sudden onset maximal headache pain. So very severe sudden onset headache pain is concerning because it's not typical, especially in a child. A headache that wakes them up out of the middle of the night and is not relieved by going to bed. A radical change from your headache history. So say you had, you know, 3 headaches a month, and now all of a sudden you're having a daily headache that is difficult to control, and you're vomiting, and you've never had vomiting before. So a distinct change. Something that is a focal neurologic sign, so maybe facial drooping, one pupil is bigger than the other, you feel like your vision has dramatically changed, you have significant ataxia, meaning an unstable walk when balancing, so a child that has ataxia is particularly concerning. Something that it triggers the headache by position is concerning. So this, we get worried about something called intracranial pressure. So if a child goes from a laying to a sitting position and then all of a sudden has an intense headache, or all of a sudden vomits, or if they're squatting or exerting pressure like a Valsalva maneuver, they bear down and they have a bad headache, that is concerning as well. In addition, a fever with a new onset, very severe headache. Oftentimes people who have low-grade fever will have a little bit of a headache, but in a kid that has a fever that's not going away and has a very severe onset of a headache, that's concerning. Immunocompromised patients, always the headaches are concerning. People who have cancer, somebody who has a shunt. Children who have a very distinct pain in a specific place, that's concerning as well. Children, usually their headaches are in the bifrontal area, whereas adults will have their headache usually in the one-sided temporal area. Also, if your child has a lot of hyperpigmented spots, so these what we call cafe au lait spots, that's a little concerning for something called neurofibromatosis, and we need to rule that out. These are also some of the indications for imaging as well. So if you're demanding imaging, you know, there's reasons why we need to do the imaging, why we wouldn't subject a child to the imaging. The other thing to keep in mind is a CAT scan is very short and brief, but it does have radiation. However, an MRI, oftentimes if kids are really little, we might need to sedate them, which means putting them under anesthesia. So we have to weigh the cost versus the benefit of doing that. The other thing that we want to talk about is what types of places are concerning for children. So kids, like I said, usually have this bifrontal pain. If they have posterior occipital pain, like it hurts when they cough or they bend over, but they say when they play, it really hurts in the back of my head, that's concerning. There's something called a Chiari type 1 malformation that oftentimes can cause headaches in children. This is when the base of the brain develops and it's a little bit lower. Very different type of headache. It is not a migraine, but it is something that we need to look after differently from migraine headaches. Another type of headache that is not migraine that we need to differentiate is called a medication overuse headache. Sometimes when we use medications to treat headaches, we use them too often. So for example, Motrin, Tylenol, Excedrin, those are great products, but if you use them too frequently, such as more than 2 to 3 times a week, you can cause a medication overuse headache. Specifically in children, we don't want to do this because it can affect their kidneys and their livers, so you want to be very mindful. As I said, kids are not little adults. So even the dosing needs to be you need to run through that with your pediatrician so that you make sure you're giving the appropriate dose. And if you're giving these medicines too much, then you need to see a headache specialist or a neurologist, especially a pediatric neurologist, specifically one who practices in headache, hopefully, that can help guide you through those transitions of those medicines. And we'll talk about medications at the end as well. Again, I need to have a disclaimer that I myself am not giving you medical advice as to what to give your son or daughter because I am not your physician, and so that would be up to your own physician. But I can give you some generalized statements regarding these medication therapies and how we use them. The other thing that can be overused is even the triptans. If you guys are familiar with triptans, these are medications that can abort a headache. The biggest thing that we see overused is actually Excedrin Migraine. In the adolescent population, all Excedrin is aspirin and caffeine. So it's like giving them a lot of caffeine in a short period of time. Likewise, the adolescent population will overuse the energy drinks because they feel that, if I have a little bit of coffee, if I have a little bit of caffeine, it will make my headache better. And that's not necessarily the truth. That can actually get us into some trouble. Medication overuse, we usually say if you're using it more, like I said, than 2 to 3 times a week, then this is a concern. You should talk to your primary doctor. Let's get into tension type headache briefly before I talk about migraine. So the other thing to rule out is a tension type headache. So this is not as much a migrainous headache, but the individuals will say that they feel the headache in both the sides of their shoulders. They'll have neck pain. The pain can kind of like creep up from the back and go forward. They'll have a lot of elevation of the shoulders. So it's interesting on physical examination. Oftentimes I'll find that someone, and it's really hard for me looking at myself in this because everything's opposite direction, but if you tilt your shoulder, I'll see patients actually kind of cock their head and tilt their shoulder, and I feel, and they have this huge muscle spasm on their shoulders and their necks. And these poor kids are actually having these heavy backpacks, and they have all these books and binders that they need to take. The other thing to keep in mind with the tension type headache is that they're bending over, playing with their phones and on the computer, and so this like text neck syndrome that is there can actually cause this myofascial or muscle spasm that can cause a tension type headache. It's different from a migraine type headache. We do treat it very differently, sometimes physical therapy. We can do a non-nutritional chiropractor, so with some deep tissue massage, some release in there. Also, we can use medication therapies for that, but that's a totally different topic. I have someone asking about pain in, around and under the eyes with a migraine. So actually, migraine headache, there can be pain out and around the eyes, but the other thing you want to rule out is a sinus headache. And this is the other thing that's confused for migraine. Actually, 98% of people that come, this is adults, the statistic is in adults, that come into a neurologist's office and say they have a sinus type headache, they actually have a migraine headache when you actually do the information with them and you get to the physical and the clinical history. A sinus type headache would be actual pain with palpation in the maxillary area here. You do have nasal discharge, runny eyes, more like allergic or even sinus like pressure. And so that would be another differential diagnosis. So that could be in that. As far as childhood migraine, which is what we're here to talk about, let me go to that first. Childhood migraine without aura is the most common type of childhood migraine. That's in 60% of pediatric patients. Typically, this is listed in a unilateral location, but this is not what we see in practice. We actually see bilateral frontal. It's a pulsating quality. It has moderate to severe pain intensity, so it's not like that dull, naggy headache. It's aggravated by doing some physical activity, and the hallmark is it has to have at least one of the following, either nausea and or vomiting, sonophobia and photophobia. So sonophobia is sensitivity to sound, photophobia is sensitivity to light. Interestingly, children frequently vomit after their migraines, more so than adults, and they'll tell you that they actually feel better. When kids tell you that they don't feel better after vomiting from their migraine, then you get a little concerned that something else is going on and you might want to do some imaging. the migraines themselves usually in children are a little short-lived, whereas adults, this can go on for days and days. Children, it lasts from 20 minutes to 72 hours, but most are 2 to 3 hours in length. So typically kids' headaches are a little bit shorter by what we see from the research studies. There's different phases of any type of migraine, and that's with children or with adults. So you can have a prodrome, which is before the headache, and that can occur up to 24 hours prior. Oftentimes people will say either they feel nauseated, or they feel hungry, or they don't want to eat. They feel funny, they feel like foggy, and they are crabby sometimes. They can actually have vision changes a little bit and just feel under the weather, almost a sick feeling and a pressure feeling. The headache will then come, and then afterwards they can have a postdromal phase, which almost is, you just feel exhausted. It's almost like you are fatigued, having trouble concentrating, but feel a little relieved, but you're not in the clear yet. So it's still part of that migraine process. And just a quick hi to everybody else who's signing on. There's a few people that just signed on. Thank you for joining us. The other type of migraine headache is the migraine with aura. So migraine with aura is a little bit different from migraine without aura. Aura symptoms can happen in children just like they happen in adults. 18% of children are going to have migraine with aura, so a decent amount. 13% will have migraine with and without aura, and then 5% have the aura, but they don't even have the headache, so you can still have those symptoms. And aura is a fully reversible visual symptom, including positive features like a bright light, flickering, zigzaggy lines, spots. Negative features means you kind of lose vision. You lose it in a certain part of your visual field. Another part of an aura can be sometimes that you have speech arrest, or you have trouble speaking. You can also have pins and needles or numbness and tingling in a particular area. As well, I should state that the aura is very interesting because usually it lasts between 5 and 60 minutes, but typically we see it at the 20-minute mark that the aura will come on. So if someone tells you, I have a headache, and then right after it I get blurry vision, that's not an aura. An aura has to be distinctly different. It precedes the headache, so it is not defined as an aura unless it precedes the headache. The aura is completely reversible. If a patient's aura is not reversible, then you get really concerned. There's also a really interesting headache syndrome called Alice in Wonderland syndrome that happens mostly in children, whereby they believe that that things look very distorted. So they'll say that someone's head is gigantic and their body is small, or vice versa. And this visual distortion is very disturbing to them, almost like in the story Alice in Wonderland. This actually is a type of migraine headache and can be treated as such. The other thing that I thought was pretty interesting, when you look at the statistics, if you look at males and females, or boys and girls, they're equal. So if you look at 7-year-olds before puberty, it's equal in percentage that boys and girls are going to have headaches in the same frequency. Whereas once you hit post-puberty, you're going to see that 5% of post-pubertal boys will have migraine-type headaches, whereas 10% post-pubertal girls will have headaches. Prior to that, when they're younger, this only happens in 2.5% of little children under 7, and then 5% of children from 7 to their puberty phase. Another interesting statistic, a quarter of the kids are going to be migraine-free by 25 years of age, but this is more common, unfortunately, for us girls, in boys than girls. So unfortunately, there is something about being female that sets us up for having these migraines. There are some thoughts that this might be related to hormonal changes, estrogen, having your menses, and that this is a challenge. More than half of individuals who still have headaches at puberty are going to keep having headaches at about 50 years old. A lot of times for women, what I meant by that is more than half of the people who have headaches past puberty are going to keep having headaches until they hit 50. For women, once we hit the menopausal state, then we also see a drop in those headaches as well. And then many times people who have children and they are a migraine or suffer, they are likely to have at least one child with migraines as well. And that's what I do see in our clinic population as well. Treatment. Let's focus on treatment very briefly, and then I'll field some questions. So in children, in the very young children, as far as headache treatments, we try really hard to do more avoidance-based treatments. So food avoidance. We try to get a good night's sleep, not skip meals, drink enough water, make sure that we're taking care of ourselves, we're relieving our stress properly. Foods to avoid in pediatric and in adult headache as well. This goes for adults too. Try to get rid of the MSG, which is monosodium glutamate. This is in the lining of soup cans, bouillon cubes, salad dressings, the fake cheeses, so fishy crackers, Doritos, ramen noodles, mac and cheese. There's some organic brands that are a little more health conscious and don't have the MSG in it. The other thing is nitrates, so luncheon meat, pepperoni, salami, bacon, hot dogs. Try to stay away from them or get the organic or the kosher kind. Red dyes, saccharin, fake sugars, chocolate, cheeses, caffeine. I tell my patients, okay, the way to remember all of this is super easy. What do you eat at a kid's birthday party? Everything I just said, right? What do you have? You have cheese and pepperoni pizza. You have subs. You have salads with probably not the greatest salad dressing on it, not homemade. You have chocolate cake. You have diet soda. You have Doritos. You have fishy crackers. So anything at a kid's birthday party, typically, is something that we don't want to eat for migraineurs. And oftentimes these kids and adults will avoid these products because it doesn't make them feel good anyway. Next, we come to what are we going to do? And like I said, we try to get them to exercise a little bit more, stretch, work on the neck a little bit. The second thing we do is vitamin-based therapy. So the studies have shown that magnesium, feverfew, and B2 are the 3 vitamins that have been helpful in practice. I can tell you that I don't see the B2 and feverfew being as robust, but the magnesium, I do see a significant improvement in many patients. Be mindful of some of the magnesiums that have citrate in it because it is what we use for bowel cleanout, so you surely don't want to give that to your child. But magnesium oxide can be helpful. Some of the challenges we have in children is they can't swallow pills, so what to do? So it's very challenging. Sometimes we have people crush things. There's gummies for certain things and then chewables for things. So this poses a problem. For the very little children, sometimes we use something called Cyproheptadine. This would be prescribed by a physician. Challenges with that medication is sometimes weight gain and sleepiness, so that's a little hard. In the older population, we were privileged to be part of the CHAMPS study, the Child and Adolescent Migraine Prevention Study, which compared amitriptyline, topiramate, and a placebo. They did find that everything was equally as effective, even the placebo. So even doing some mindfulness, meditation, and rest can be helpful. But there is a subpopulation of kids that are difficult to treat, and they do have very severe headaches. And those other medications are very helpful for them. And we do have other medications that we use, especially if there's comorbid issues such as depression or anxiety or neck pain. We may deviate from the traditional treatment plan to help treat multiple things.